Okay, sir. Okay, sir. Sir, we are live now.
Okay, yeah. Thank you, Viraj. Good evening, doctors. On behalf of Alchem Laboratories, India's fifth largest pharmaceutical company, I'm Balaji. Take great pleasure in welcoming all the eminent doctors who have joined us for today's panel discussion. Doctor, today's panel discussion will be on titled Views on Vildagliptin. Doctor, at Alchem, it has always been our endeavor to partner with healthcare professionals, and we will continue to do so even in these challenging times. To help us to navigate through the entire meeting, we have with us today Dr. P.G. Sundaraman sir, who will be our moderator for today's panel discussion. Welcome, sir.
Thank you.
Take this opportunity to give a short introduction about our moderator, Dr. Sundaraman sir. Dr. P.G. Sundaraman sir is a senior consultant endocrinologist who is practicing at Chennai, who is well known to all the doctors in Tamil Nadu. Doctor has done his DM endocrinology in AIMS, and he has published several publications, close to 9 publications doctor has got. And doctor has also contributed several topics in various textbooks in endocrinology. He has almost contributed 4 different topics in different textbooks in endocrinology. The doctor also has done several orations. He has done 3 orations: Dr. GVN oration, Dr. Ramadas oration, and Trendo presidential oration. And also, doctor is award recipient of various awards. He has been awarded a Best Doctor Award from Dr. Tamil Nadu MGR Medical University in the year 2012. Doctor was also holding various positions in Endocrinology Association. He was a past president at the Endocrine Society of Tamil Nadu in the year 2015 and 16. With this short introduction, I once again welcome Dr. Sundaraman sir. Welcome, sir.
Thank you.
Let me take this opportunity to welcome all the panelists. Firstly, I'd like to welcome Dr. G.S. Vijayalakshmi madam. Dr. Vijayalakshmi doctor is a consultant diabetologist who is practicing at Chennai. Doctor has done his MBBS in the year 2001 from Annamalai University, and doctor has also done her post-graduation in the fellowship in diabetology at Dr. Mohan's Diabetes Center in the year 2006. And doctor is currently doctor is associated with the KM Specialty Hospital, KK Nagar, Chennai. Doctor was previously associated with the Hindu Mission Hospital, Nanganallur, and Dr. A. Ramachandran Diabetes Specialty Hospital and Medford Hospital. Doctor is currently associated with the KM Hospital and Voluntary Health Services, Chennai. With this short introduction, I welcome Vijayalakshmi madam. Welcome, ma'am. Let me take this opportunity to welcome the next panelist, Dr. Shivamohan sir. Dr. Shivamohan sir.
I'm just a doctor from Dr. Shiva's Diabetes Care. I'm a diabetologist, that's all. Let's cut it short.
Yeah. So Dr. Shiva's Diabetes Care, Dr. Shiva's Diabetes Care, Chennai, Ashok Nagar. Welcome, sir.
Thank you.
Take this opportunity to welcome the next panelist, Dr. Vijayalakappan sir. Dr. Vijayalakappan sir is a consultant physician and diabetologist who is practicing at Chennai. Doctor is having a own clinic at Kodambakam, and he was also visiting consultant at various hospitals. Doctor is currently visiting SRM Hospital at Westmambalam, and he is also associated with this own clinic at Ashok Nagar and Kodambakam, and he is also visiting consultant at various hospitals and nearby Ashok Nagar and West Mamula. With this short introduction, I welcome Dr. Vijay Laghavan, sir. Welcome, sir.
Thanks for the introduction.
Sir, I'll hand over the session to Dr. Sundaraman, sir. Sir, you can set the context for the webinar and you can get into the topic, sir. Over to you, sir.
Okay, dear colleagues and friends, at the outset, I wish to thank Alchem for giving me this opportunity. In fact, it's a pleasant evening in a turbulent environment. You know that very well, that we are in the midst of a pandemic situation, and also the cyclone is crossing between Odisha and West Bengal. Now, it's quite interesting that we realize that the COVID-19 enters the various cells through the ACE receptors. And they found out that TPP4 is one of the core receptor which helps in the entry of the coronavirus. And there are studies which have shown that this is upregulated in aging population, in people suffering from respiratory illness, cardiovascular disease, and diabetes mellitus. So there were some elegant studies of how the DPP4 inhibitor can, to a very great extent, decrease the morbidity and later on the mortality in this pandemic situation. And coming to the crux of our meeting, in fact, we are going to discuss an interesting molecule, variable is the vildagliptin. Diabetes is a complicated disease and a complex disease, which is not only related to glucose metabolism, but it is related to the entire metabolic milieu of the body. And if you take the two important mechanisms which gets deranged in diabetes, one is the signaling pathway, another is the secretory pathway. And how this is going to take care about these two things, because we realize that the enteroinsular axis is one of the important stimulant for the islet cells, especially the beta cells, and also its effect on the alpha cells. Vildagliptin was first synthesized in the year 1998 in the month of May, and it was named after Edwin B. Villor. And it was subsequently becomes used around 2007 and 2010. And this molecule was quite efficient in handling the glucose metabolism, and why the current scenario has been slowly shifting from insulin secretagogue management to the other options, very well, the octet. Now, we have amongst us three eminent speakers, and it's quite interesting that how this molecule is helpful in various situations. And also, we know that how combination therapy can be a very effective mode. In fact, they have found out that the effective control of blood glucose like early intensification is very important in reducing the vascular complications. And it also has a very big lineage on the legacy effect. Now for this, we have Dr. Vijay Alagappan, who is going to talk about what is the VERIFY study and how is it relevant in the intensification management. I call upon Dr. Vijay Alagappan, please.
Thank you, Dr. Sundaraman, sir, for setting the tone perfect for the evening. To start with, I'd like to thank the team of Balaji and Alchem for inviting me, along with the panelists of my close friend, Dr. Shivamogan and Vijayalakshmi ma'am.
You can open the video, please.
Yes, sir. Yes. So to start with the VERIFY study, this was the purpose. VERIFY study was the purpose of the study was to determine whether the initiation of vildagliptin plus metformin combination regimen would result in more durable glycemic control than metformin monotherapy in treatment-naive patients with type 2 diabetic mellitus. So this was the primary motive of this particular study. So to have a detailed description of this study, it was a multi-center, double-blind, placebo-controlled, two-arm parallel group study with a run-in period for up to 5 years. So the main motto is, if at all, if you can initiate vildagliptin plus metformin at the time of diagnosis itself, one arm of the particular study, the other arm is with metformin alone and uptitrating the dose of metformin. So at the end of so-and-so years, what we would try to achieve is the better HbA1c control. So this is the primary motive of the study. The study was published in the results was published in the year 2019 EASD over there in Spain, Barcelona. So there are 2 periods were there with the study, like metformin up to 1000 milligram twice a day plus vildagliptin 50 milligram twice a day versus metformin, the other arm was with metformin 1000 milligram plus a matching placebo twice a day was given. Duration of period 1 could differ between patients depending on the time when the second of 2 HbA1c measurements taken at 2 consecutive visits after randomization confirmed HbA1c of more than 7%. So what we found out in that particular study was the time to initial treatment failure was noted. So the treatment failure was defined as 2 consecutive scheduled visits with HbA1c of more than 7% starting from 13 weeks after randomization. And the time to treatment failure was the number of days from randomization to the second of the consecutive scheduled visits. So participants who discontinued the study for any reason during period 1 was censored at the time of discontinuation. So the secondary, this was the primary outcome measures, and participants who remained under the threshold were censored at the date of last study visit. So the primary outcome was time to initial treatment failure. And the secondary outcome measures, what we found out through this VERIFY study was rate of loss in glycemic control during period 1 and rate of loss in glycemic control in HbA1c over time during period 2. So these 2 things were noted. And other multiple classification like rate of loss of beta cell function, rate of cell and insulin sensitivity, all these things were studied. And at the end, the eligibility criteria was from the age group of 18 to 70 years. Key inclusion criteria was the patient should be treatment naive, BMI more than 22, less than 40, HbA1c more than 6.5 up to 7.5 at visit 1. So all these things were key inclusion criteria. And what we found out at the end of the study was to have since other panelists are there, I'll directly go into the results of the study. So VERIFY study was proven to be a superior one, if at all it has been initiated early, and whatever the target HbA1c control we try to achieve at the end of 5 years. It's been achieved by around 3.2 to 3.7 years itself. That is less than 7% when compared to the other arm. So instead of going for an conventional approach, if you can have an intensive treatment protocol at the time of diagnosis, particularly with a molecule like DP4 inhibitor and metformin, in particular with the study of Verify, vildagliptin 50 milligram twice a day plus metformin 1000 milligram twice a day, achieved an HbA1c target of less than 7 in a period of 3.2 years, and it has been consistently maintained over a period of 5 years. So this was the primary outcome of this study. And the other secondary outcome is also being met with this particular study when compared to the other arm, where the other arm had metformin 1000 milligram twice a day plus a matching placebo twice a day.
Yeah, it's quite interesting that this Verify study was done in the age group between 80 and 70, and the BMI was also ranging drastically, and in a drug-naive patient, where compared to the metformin and placebo group, the durability of the therapy and also the early intensification, which has got a significant effect on HbA1c. Now, how it really worked in as a diabetologist perspective, I call upon Dr. G.S. Vijayalakshmi to give her comments on this.
Thank you, sir, for the opportunity. I would like to thank Alcom for this opportunity to join you people in this evening. First of all, we all know that type 2 diabetes is a slowly progressive disorder, and from data from UKPDS, we all know that there is a 50% beta cell loss right at diagnosis of diabetes. And since it's a slowly progressive disorder, we have to choose agents that do not exhaust the beta cell faster.
Switch on the video, please.
I'm actually on my way to the driving, so
sorry. Okay.
yeah, so that's why I'm in the car, so I think it's better.
Fine.
Yeah.
Okay.
So we have to, as physicians, choose agents that would kind of preserve the beta cell for a long term for the patient. So obviously, for any patient, the initial treatment would be lifestyle modification, because we've seen in numerous studies right from the diabetes prevention program, we know that lifestyle modification has a major role in reducing the insulin resistance and therefore improving the insulin sensitivity and preserving the beta cell reserve for a longer period of time. And next to metformin, I think DPP4 inhibitors have come to stay as the next line agent, because we all know that it kind of complements the action of insulin through the incretin pathway. And therefore, without causing much of beta cell exhaustion, it is able to achieve a good glycemic control early on in the course of disease. Again, to quote from UKPDS, we know that UKPDS is a study that was done with patients who are newly diagnosed with diabetes. So from that study, we know that when we intervene early on in the course of the disease, if we are able to achieve a good glycemic control, these patients have a long-term benefit. The follow-up study of UKPD is more than 20 years. We know that even after the narrowing of the arm between the intensive control arm and the standard control arm, the good glycemic effect that the patients received during the intensive treatment, that is when the HbA1c was maintained close to 6.5%, less than 7%, that good glycemic effect translated into long-term benefits in terms of reduced both microvascular and macrovascular complications. Therefore, intervening early on in the course of the disease with the agent that is able to give a good glycemic control without causing hypoglycemia. Now, we all know that DPP4 inhibitors do not cause hypoglycemia by itself, but when it's given with other sulfonylureas, we have to use it cautionally. With caution. The sulfonylureas has to be probably the dose reduced, or if the patient is on insulin, the insulin dose titrated so that the patient doesn't go into hypoglycemia. But by itself, DPP4 inhibitors do not cause hypoglycemia. And that also is an additional benefit to our patient, because we all know of this factor called hypo-obesity. The patients, when they're put on sulfonylureas, because of the fear of hypoglycemia, tend to eat more to prevent the next episode of hypoglycemia, because sulfonylurea's mode of action is it induces the insulin secretion irrespective of the patient's meal timing, lifestyle, and all that. So the patients, especially the old generation sulfonylurea like glibenclamide, have a very strong propensity towards hypoglycemia, and therefore the patients, to prevent such hypoglycemic episodes, tend to eat more and they put on weight. So every 1% drop in HbA1c that is achieved through hypoglycemia, through a compromised glycemic control by causing hypoglycemia and all, is offset by the the ill effects of hypoglycemia and the weight gain that the patient gets. So that's another great advantage of DPP-4 inhibitors in terms of being able to achieve good glycemic control without causing hypoglycemia. And especially when we talk about hypoglycemia and in terms of elderly patients, we all know that they're already a frail population, and hypoglycemia and which can induce falls and all that is not safe for our elderly diabetic population. So therefore, this molecule can be used early on in the course of the disease. It can be safely used for elderly patients as well, because it doesn't cause hypoglycemia. And it kind of can be used along with, in combination either with metformin or other sulfonylureas. It can be used across the spectrum of the disease, and it's still, and as we saw in this trial, that it not only offers good glycemic control, but the durability of this molecule is also proven in this trial. Anything you'd like to add, sir? Hello?
Yeah, ma'am. Ma'am, I think Dr. Sundaraman sir is facing some technical issue. I'll just check this.
Hello, can you hear me now? Yeah.
Yes, sir. Yes, sir.
Yeah. The compared to the Caucasians, the Asian profile, we are thin fat individuals, and the pharmacokinetic properties fits with the profile of the Asians. And you're very correct that the main problem with our population is beta cell abuse. So preservation of beta cells becomes an important factor. Now, you know very well that the DPP-4 inhibitors not only upregulates GLP and GIP, but it also has an effect on the stromal derived factor 1 alpha and the pituitary adenylate cyclase activating polypeptide, which improves the islet function. And she was very correct that the durability is more when you intensify the treatment initially itself, when you give a combination therapy, especially whether it is going to be a metformin or sulfonylurea, it is definitely in a long run going to have a good effect on the vascular complications. Now, I request Dr. Shivamohan to clarify on this aspect, how this is basically relate to the legacy effect. Now, how this has been shown to have some legacy effect.
So thank you very much, Sundaraman sir, for being the moderator. I want to thank Alkem, diabetology unit, and I also am very happy to co-present with my dear friend Dr. Vijayalakshmi sir and Dr. Vijayalakshmi ma'am. So, legacy effect. Okay, one of the main culprits behind legacy effect, or what we call as the metabolic memory, one of the main culprits is age, advanced glycation end products. There are actually many pathobiological pathways, to complications of diabetes, say the polyol pathway, age pathway, protein kinase pathway, exosamin pathway. But for the legacy effect, one of the main culprits is the age pathway. And vildagliptin seems to have an effect on downregulation of age receptors. So that's what some studies have shown. So, the UKPDS, again, it has shown that, the importance of the legacy effect, what can have, in the consequences of the bad legacy effect, that is the microvascular and microvascular complications. Now, one of the main reasons for this legacy effect or the activation of this pathway is oxidative stress. That's the starting point. That's the tip of the iceberg, and then it branches out into different pathophysiological, complications. So, Vildagliptin also helps in reduction of this oxidative stress, which is the tip of the iceberg. So, and also it has effects on inflammatory pathways. Like it reduces the expression of transforming growth factor. It also reduces the expression of tumor necrosis alpha factor. It increases the expression of plasminogen activator inhibitor. So these are the ways through which it helps in preventing vascular complications. It's the ultimate endpoint of legacy effect. So that's how I think Vildagliptin has an huge influence on legacy effect when it comes to complications of diabetes.
Yeah, it's quite interesting that.
Sir, I'm really sorry to interrupt, sir. I just wanted to add. Generally, sir, all these years, we've been learning that diabetes is a metabolic vascular disorder due to changes in the fat, glucose and protein metabolism. But I think we have to also include that it is not only a metabolic vascular disorder, it is an inflammatory disorder, because ultimately that's what it leads to, inflammation. So all these inflammatory cytokines like, tumor necrosis alpha, NK beta cells, all these things lead to vasoconstriction. It also leads to, reduction in nitric oxide synthase, which is a potent vasodilator. Because when we see, like you said, sir, Sundaraman sir just said that, we have a thin fat, we're all thin fat Indians, which is nothing but Asian phenotype people. For us, compared to a Western population, our metabolic load is more and metabolic capacity is less because our length of the muscle is very less. Whereas in Western population, length of the muscle is more, so they can, they can metabolize glucose very efficiently. So we have lesser load. So in that case, it's very important to, when there is less metabolic capacity, there is more insulin resistance, and this insulin resistance leads to reduction in nitric oxide synthase, which ultimately leads to vasoconstriction. So it's a combination of so many things put together. Sorry for interrupting, sir.
No, you're very, very correct. In fact, I was about to tell that it's an interesting study in South Korea where they've used a DP2 inhibitor as one of the anti-inflammatory, as anti-diabetic in the management of COVID also. And you're very correct that if you take that, the basic problem lies with the insulin the glucose consumption and the insulin secretion. Now, you are very correct that as an Asian, we have got sarcopenia. The muscle bulk is very much reduced. And also the signaling cascade for the peripheral uptake of the glucose is also impaired. And there is also an ongoing beta cell secretory defect. Now, that is a reason why they have, in a verified trial, where they combine the Vildagliptin with metformin. And this has definitely intensified, as you told, that it takes care about both the angles to a great extent. And also, they have found out the glycemic variability can, to a certain extent, being curtailed. And in this context, is very essential that as we move on to the effect of Vildagliptin in CKD, and what is your perspective?
So mine, sir?
Yeah.
Okay. So do you want me to speak about it generally, or do you want me to stick to the study?
I think both yourself and Vijay Alagappan, I think he can talk about it.
Okay, sir. So I'll go ahead with that, sir. So I think one of the main causes of CKD has always been diabetes, and almost you have to have other comorbidities like hypertension for a faster development of diabetes. When there is hypertension, about 40% of these people go on to develop CKD. And most of the people with CKD, like with mild renal impairment, are actually undiagnosed. So first, it's a very difficult situation when there is CKD. People go on to develop end-stage renal disease. So when it comes to diabetes management in CKD, so there are various drugs which cannot be used in terms of end-stage renal disease. For example, metformin. So in less than 30 mils per minute of eGFR, so metformin cannot be used. Or metformin's dosage should be reduced when the eGFR reaches about 45 mils per minute. And we don't have adequate data for alpha glucosidase inhibitors. And when it comes to sulfonylureas, we have to be extremely careful when the eGFR reduces to less than 60 mil per minute, because it's going to prolong the duration of action of sulfonylurea. So there is always the risk of hypoglycemia. Now, when it comes to DPP-4 inhibitor, there's only one gliptin, which is the linagliptin, whose maximum excretion is through enterohepatic circulation. So when it comes to vildagliptin, so it can be used in stage 4 CKD and end-stage renal disease also. So when it comes to stage 4 CKD, so the dosage of vildagliptin can be reduced to half, that is 50 mg. Generally, we take 100 mg OD. Taking 100 mg on a 24-hour basis. Taking 100 mg on a 24-hour basis can have a huge impact on the DPP-4 inhibition. But in CKD, we have to reduce half, and it can be taken in end-stage renal disease also as 50 mg on a OD basis. So there has been studies done in elderly people, more than where people were more than 75 years of age.
No, we'll touch the topic on the next topic regarding the CKD. I think you have told that how that we are going to set a target of 30, where when the other molecules which are contraindicated, and also the importance of sulfonylurea in causing hypoglycemic episodes, and whether vildagliptin along with the other agents it's out of interest. What is the vildagliptin along with the SGLT2 inhibitors, and what are your perspective in the? I request Dr. Vijay Alagappan to give his comment, please.
As Dr. Shivamogan rightly pointed out, there should be some dose titration once we cross the chronic kidney disease stage 2, sir. From vildagliptin, particularly stage 3A and 3B, we have to use a dose of 50 milligram once a day. And from CKD stage 4 and stage 5, it is 25 milligram once a day. So, and if you can combine SGLT2 inhibitors, recently we had a study published in the ESC 2020, DAPA CKD, which was published last year, said like till eGFR 45, you can use an SGLT2 inhibitors. Along with the gliptin, definitely it does wonders. Even the progress of eGFR is being halted to some extent, and definitely the reversal of microalbuminuria is also being noted. And we learned from them, like still the studies are going on in between 30 to 45 also. Another good thing about treating a patient with CKD, that is even a non-diabetic patient can be treated for CKD with SGLT2 inhibitors. That was one of the prime thing which was published in that particular DAPA CKD trial. Combining vildagliptin with an SGLT2 molecule definitely has a lot of benefits. Apart from the routine benefits, we have other pleiotropic benefits too. So since DPP-4 inhibitors being a weight neutral molecule, SGLT2 being a weight reduction molecule, and to some extent there is a mild reduction in terms of hypertension also. And major thing what we try to as any diabetic patient, to certain extent, definitely the progression of the disease will be on higher side. So to some extent, definitely the kidney progression will also be there. If at all, if we can initiate at the early part of diagnosis itself, the same combination of DPP-4 inhibitor plus SGLT2 inhibitors, definitely the progression of the disease, both in terms of diabetes related complication and particularly nephro-related complications, definitely can be halted. So the main eligibility criteria to prescribe an SGLT2 inhibitors along with an DPP-4 inhibitors will be this EGFR. Based on that, we can initiate it, and definitely that will do wonders both in terms of preventing complications. In this particularly, this nephropathy complications can be prevented.
Yeah, it's very interesting.
I would like to add to that thing, sir.
Definitely, Vijay.
So, like, as we all know, the pathogenesis of diabetes, I'm sure all of us have heard about this omnius octet. So when we combine a SGLT2 inhibitor along with a DPP-4 inhibitor, it kind of addresses 6 of the pathogenic factors that contribute to the type 2 diabetes. And when it's used in a combination of metformin, it kind of addresses most of the things, including the insulin resistance, increased hepatic glucose output, because DPP-4 inhibitors target the glucogen secretory defect. The incretin axis secretory defect is again addressed by the DPP-4 inhibitors. SGLT2 inhibitors reduce the glucose reabsorption. So all these kind of complement the metformin action, and without the use of sulfonylureas, if we can early on target the insulin resistance and the other insulin secretory defects, it kind of in the long term, it's going to contribute to the preservation of beta cells. And therefore, as the previous doctors rightly said, if we can target these axes early on in the course of the disease, we can prevent the long-term complications. When
it comes to this combination of both these drugs, the only thing is the aspect with SGLT2 is it can increase the endogenous glucose production. So because much of insulin is not involved. So when there is increase in endogenous glucose production, obviously with the fasting blood sugar will go up. So that's where a combination with DPP-4 inhibitor can help us in down-regulating the glucagon production or endogenous glucose production by having an impact on the glucagon. So there was this study done where dapagliflozin was combined with saxagliptin, and it was seen that there was in combining when dapagliflozin was given as monotherapy, it reduced HbA1c by close to 2% or something, 1.28. And when saxagliptin was given as a monotherapy, it reduced HbA1c by close to 0.7 or something. When there was a combination of dapagliflozin and saxagliptin, so it reduced HbA1c by 1.4%. So there was not much difference between combination of SGLT2 and DPP-4, and when SGLT2 was given as a monotherapy. So separately when given, they have huge effect, but when combination it has lesser effect. So one of the reasons for this is as the HbA1c increases when you give a SGLT2 inhibitor, it exerts more of its action. So there is more of endogenous glucose production, on which the DPP-4 cannot really work efficiently. So when this combination will work best when the HbA1c is less than 9%, because more than 9%, the SGLT2 inhibitor will be exerting a lot of effects. So the DPP-4 will not be able to cover that effect of SGLT2 inhibitor on the endogenous glucose production, and the HbA1c is more than 9%. So that was my view, sir. Thank you.
Yeah. It's very interesting that the glucagon, especially the vildagliptin, is inhibiting the hepatic increase of glucagon. That is one of the important parameters where the hepatic glucose production is also curtailed when you give vildagliptin, especially the gliptins. And as you're correctly told that whenever it depends upon the HbA1c, when the overriding mechanism is going to operate, it becomes a counteractive mechanism where one nullifies the other. So it's once again very interesting that in the kidney disease, where we need to titrate the dose, whatever drug you're going to use it. And the next topic is going to be about the elderly patients. Now, how are we going to, especially in the context of vildagliptin, Dr. Vijayalakshmi, can you give your perspective, please?
Yes, sir. Before we move on to the topic of elderly patients, one more point I wanted to add it, like when DPP-4 inhibitors and SGLT2 inhibitors are used in combination, the rate of urinary tract infections have also shown to be lesser when this combination is used. There is a particular study that kind of has shown this decreased rate. So moving on to the topic that you spoke about, the elderly population. We all know that the elderly population, the risk of hypoglycemia is a very big concern when it comes to achieving good glycemic control. So we know that from all the various international guidelines, we have to be very specific in setting the right target for the patient. When a patient is very young and has a long life expectancy and is very motivated towards controlling their blood sugars and all that, then we have to be setting a very strict glycemic target of fasting postprandial and a HbA1c of less than 6.5 to 7%. Whereas in case of elderly patients, like the various trials have shown, and if we kind of try to achieve a very strict target, we're probably doing them more harm than causing them good. So therefore, we have to set a less stringent HbA1c target and avoid hypoglycemia. So that's where DPP-4 inhibitors really come in as a boon in this group of elderly population, because the incidence of hypoglycemia is really less when it's used in this group. And when it's used along with other agents, like when it's used with sulfonylurea, or if the patient is already on insulin, then we have to take care that when we introduce any new molecule, we titrate the dose of either the existing sulfonylurea or this insulin so that the patient doesn't go into hypoglycemia. That's one thing we have to watch out for, especially in the elderly population.
Yeah, it becomes a patient-centric approach as the age advances, and also, you know very well the role of GLP and GIP, how as the age advances, it has got the effect is also nullified. I request Dr. Shivamohan to give his comment, please, on elderly patients, vildagliptin on elderly patients.
I think as the age increases, the risk of, there is going to be a lot of comorbidities. So there's going to be existing hypertension, dyslipidemia, coronary artery disease. There's going to be a lot of complication in elderly people. So we have to ensure a proper efficacious treatment in the absence of hypoglycemia. And also we have to know that, glycemic variability is directly proportional to asymptomatic hypoglycemia. So again, because it can lead to a lot of cognitive dysfunction, hypoglycemia in elderly people. So and they're going to have pre-existing cardiovascular problems. So and there was a study which was done where they wanted to find out the efficacy of vildagliptin in elderly people, and who are almost more than 65 years of age, and people who are less than 65 years of age. And they found that elderly people had more added medications compared to the ones who are younger to them. So in spite of all the complications, there was no significant, the safety of vildagliptin was very good in terms of hypoglycemia. And in fact, there was lesser weight gain. And giving vildagliptin in elderly people had better HbA1c reduction. And it had better weight reduction also in elderly people compared to people who are younger to them. So I don't know, probably, yeah, when it came to, mild renal impairment, which is actually unnoticed in this, elderly people. So it did not have any effect in eGFR of elderly people as well as the younger people. So the safety is also important in elderly. The efficacy is also very important in elderly. So in both ways, vildagliptin is very effective in elderly, and when compared to younger populations.
Yeah, it's quite interesting that that is the reason why there are a lot of failure rates when you use insulin secretagogues compared with the gliptin because of the fear of hypoglycemia. The compliance also is very important, and you also touched upon the multiple comorbidities requiring a lot of medicines. I request Dr. Vijay Alagappan, what is your context, whether there are now vildagliptin is given as a single daily dose, 100 milligrams. Now, whether that is going to give a boost to them in a compliance, and how it's going to be effective, and what is your comment on it, please? A single dose compared to the
Yes, sir.
twice daily dose.
Yeah. Of late, for the last 6 months or so, there is a molecule with the vildagliptin. It has been released as 100 milligram once a day, sustained release, all these things. But it is from the innovator side, from the company of Novartis. They don't have a molecule of 100 milligram sustained release once a day. Then we don't have studies and data to say like 100 milligram once a day is equivalent to 50 milligram twice a day. As far as both in terms of efficacy as well as other adverse events are concerned. The only difference with this 100 milligram sustained release and the other thing is the tablet release form is different. It seems like some kind of a gel matrix technology or something is being done so that the drug release pattern is being altered. And there's a small study, it's been done with around some 30 patients in this group of 100 milligram sustained release with 50 milligram twice a day. Over there, what they have told is, as far as HbA1c reduction is almost similar to 50 milligram twice a day and 100 milligram once a day. Other than that, as far as other adverse effects like the GA tolerabilities and other thing is not being widely studied. So my take on this particular once a day drug is I have not used it till date, since there are no data to prove that like 100 milligram is superior to 50 milligram twice a day. And from the innovator side also, it has been clearly evident like it is only the drug pattern release matters when compared to it is not a different molecule, it's the same molecule, but the release of the drug pattern is different. Other than that, I don't see any other changes, sir.
I also totally agree with Dr. Vijay, because one thing is we also don't know about the QT prolongation. There are very few studies, again, involving small number of patients where 100 milligrams of vildagliptin has showed some QT abnormalities. So apart from one thing of improving the compliance of patient, because when we give 2 pills, definitely a single dose is going to improve the compliance of the patient. As physicians, I think twice a day, along with the combination of metformin itself, is doing a good job in terms of glycemic control and all that. So we'll have to wait for more evidence in terms of cardiac safety before we start extensively using this 100 milligram once daily. Your take on it, sir?
Yeah, you know very well that the terminal elimination half-life is around 90 minutes, and more than 50% inhibition of the DPP4, especially for 10 hours. And basically, I have not started on 100 milligrams, so once a dose. I'm still giving twice dose 50 milligrams. But there are instances where some people they just see there is a different forms of management that as a diabetologist, though it is prescribed as 50 milligrams BD, many times is given as a 50 milligrams OD dose also. There are studies where, but they have shown with the 50 milligrams OD dose, it is not as effective as you give 50 milligrams twice daily. And you are very correct. I was also a little bit concerned about the QT prolongation when you give a higher dose as a single therapy. We must use it in a bigger number to have the correct answer. And next, moving on to the what is the comparison with other gliptins? Just for the audience sake, you have got the peptidomimetic and non-peptidomimetic gliptins. Can Dr. Vijayalakshmi highlight on this and tell which group the vildagliptin belongs and how is it taken in comparison to the gliptin, how far it's going to have an effect on DPP4, and how far it is have an influence on 8 and 9 and FAP. And these are all very important as measures for the various complications.
Yes, so compared to the other gliptins, vildagliptin has the highest affinity towards DPP4 inhibition compared to whether it is Sita or the other gliptins. Vildagliptin is shown to have a higher affinity. So therefore, even in my clinical practice, I always talk from a clinician point of view. I think it's safe to say that vildagliptin has shown a very good glycemic control compared to other gliptins, probably attributed to the higher affinity it has to this specific enzyme.
Vasudeva.
Dr. Shivmohan, what is your opinion, please?
I think so. It again boils down to I really don't know about this in detail about this peptide cleavage and all those things, to be very frank. So I just go ahead with the DPP4 inhibition because there has been studies where vildagliptin 50 mg twice a day has been compared with sitagliptin 50 mg once a day, and it is shown to have had better more than 90% of DPP4 inhibition, and again that's how much I know.
Yeah, that's what I was telling on the previous this thing.
Because this 50 mg of vildagliptin acts for close to 8.5 hours.
Yeah. And
100 mg acts to close to 12.5 hours. So
yeah, the
we need
area under curve is 10 to 12.
Yeah, so we need twice a day, vildagliptin to cover more than 80% of DPP4 inhibition.
And also decrease the GB and time in range. Yeah.
Yeah. So
what of Vijay Alagappan? Can you give some comment, please?
So as rightly pointed out, the affinity of this particular DPP4 inhibition is far superior in vildagliptin when compared to other gliptins, so that time taken to react and the half-life is far better in terms of acting when compared to, as Shivmohan also rightly pointed out, instead of giving once a day 100 milligram vildagliptin, where the inhibition will be not on the proper side. If at all, if you can give twice a day, definitely the inhibition will be on the proper side. And as you also mentioned, sir, the time in range also has to be addressed. So as rightly pointed out, the inhibition plays a huge role in terms of the release of drug pattern, so that efficacy cannot be altered. So I do agree with this thing, sir.
Yeah, another interesting phenomena that they have shown that how far compared to the other gliptins you come across nasopharyngitis and pemphigus lesion. Any of you can. So that also has a role to play on the 8 and 9 and the FAP. I didn't see much. I have seen with the Sita, a lot of patients had nasopharyngitis compared to the vildagliptin. I didn't see, but even Sita, I have seen a couple of patients with pemphigus lesion. We have stopped it. Saxa also we came across. And now, what is your opinion about this? Any of the speakers can answer to this question. The complications.
I've seen one case, just one case of pemphigus. It's all with build-up. Otherwise, it's relatively safe.
Yeah, and it's quite interesting that one is the importance of the early combination therapy, and when you combine with the metformin, it becomes very ideal. Whenever there is going to be a problem with metformin, there are also studies with pioglitazone where they have used it. But the problem with the combining a pioglitazone with vildagliptin, the edema is going to be a problem in these patients. And also it depends upon the cardiac failure. So gliptin, though in a cardiac failure, it has got a slight edge more for that. There are combination of the vildagliptin and sulfonylurea, vildagliptin insulin. So a lot of combination there. What is your whenever they are not able to tolerate the metformin, what is the you just leave it SGL2 inhibitor, you leave it. The other combinations which think. Which
So, and when it's used in combination
in a routine practice.
In the routine practice, when it's with DPP4 inhibitors are used in combination with the new generation sulfonylureas like glyclazide or glimepiride, the incidence of hypoglycemia is relatively lesser, because we all know that glimepiride and glyclazide are relatively, their affinity of association and dissociation with the sulfonylurea receptor is much faster and quick. So therefore, the incidence of hypoglycemia is relatively less for the new generation sulfonylureas. So when the patient is not able to tolerate metformin, or even otherwise, I think most of our patients would be on a combination of metformin, sulfonylurea, and vildagliptin, and it's relatively very safe. And this combination is able to achieve a good glycemic control also. And at the end of the day, all said and done, when we are treating patients in India, definitely the cost effectiveness is there, and sulfonylureas is still the best cost-effective molecules available in the Indian market. So therefore, when vildagliptin is used in combination with metformin and sulfonylurea, it really works well. And I'm sure all of us also have patients who are on insulin with this combination of vildagliptin or sulfonylureas. And again, as I said earlier, if you're going to use it in combination with insulin, we just have to make sure that we titrate the insulin dosage when we initiate any new drug, so that the patient doesn't go into hypoglycemia.
So Shivmohan, in a patient already on insulin was not able to be in control, what is your opinion of adding vildagliptin to that?
Sir, insulin in the sense only they're taking insulin as a
insulin
monotherapy?
plus secretagogue.
Insulin and a secretagogue.
Yeah.
So think
type 2 diabetes.
Type 2 diabetes. So again, it depends on whether it's an elderly population or a younger population. So again, if it is going to be an elderly population, then the risk of hypoglycemia is going to be more. So if you're going to add vildagliptin, because again, I told you as age progresses, there's going to be brittle diabetes, if the duration of diabetes also more along with age. So with brittle diabetes, there is going to be a lot of peaks and lows in terms of glycemic status. So we need a drug which will really take care of this glycemic variability. So you can, if the patient is already on sulfonylurea and an insulin, so if you're going to add a vildagliptin, probably you can try changing the if it is a premixed insulin. And probably if you're going to add a vildagliptin, you can try changing it to basal. Again, it depends on the HbA1c. So you can try changing it to basal, so that it will reduce the it'll make it more convenient to take it as once a day basal insulin along with vildagliptin. So in elderly people, so if you just take almost 60% of people with diabetes, or 60 to 70% of them are not under control. So we can see so many people with more than 9% of HbA1c. So in that person, again, you can, when you're going to start them on vildagliptin, you can reduce the dosage of sulfonylurea over here. Because the more recurrent hypoglycemia you're going to have, you're going to damage your autonomic nervous system. So that will ultimately lead to hypoglycemia unawareness as the age progresses. So to prevent all this, vildagliptin can actually prevent glycemic variability by giving equal efficacy as that of any other drug when it comes to combination therapy. And there is not going to be weight gain also with combining a vildagliptin with another drug like sulfonylurea and insulin. So the only thing which we can address over here is there's going to be good efficacy without weight gain with least risk of hypoglycemia when you combine vildagliptin with insulin and sulfonylurea combination.
Yeah, you're very correct. When you have a patient with insulin plus sulfonylurea, many times they go into recurrent episodes of hypoglycemic, this thing, especially in elderly population, where we can reduce the dose of sulfonylurea, put them on vildagliptin, and titrate it with insulin. That will be better. And you correctly told that the basal insulin has got a good coverage of this thing. Dr. Vijay Alagappan, what is especially what is in the scenery of pandemic COVID, a patient on vildagliptin, what is your take-home message, and how are you going to approach these patients? Whether you're going to stop the DPP for vildagliptin and put them on insulin, what is your
If you
approach?
take in this particular pandemic, if the patient is tested to be positive for COVID-19, and probably we have to assess the severity, and based on that, we will be treating it. Probably if the patient is having a score of CT score of less than 8 or 9, mostly home isolation, and being a diabetic, we will just advise them to be to monitor their sugar level closely, and if the sugars are very well within the normal limits, both fasting, postprandial, as well as HbA1c, definitely we don't disturb the patients who are on vildagliptin with metformin combination. So definitely tight glycemic control is the need of the heart, particularly in this pandemic. So to prevent complication, already they are in the immunocompromised state, and definitely having COVID, again they will be falling into the immunocompromised state only. So to have a better outcome, definitely their glycemic status should be very well within normal limits. If at all, if they are hospitalized for some other reason due to COVID positive or so, and probably, and if there is a need for the treating intensivist to initiate a steroid-like molecule, definitely the sugars will be on the higher side. So at that point of time, they will be treated with insulins, and SGLT2 is contraindicated, particularly during COVID. And once at discharge, definitely they will be still on some kind of steroids and anti-inflammatory tablets, all these things. So insulin will be the first choice, and along with that, definitely gliptin plays a role. We can continue with the same dose of gliptin, whatever has been continued prior to admission or so. And if there's a requirement, slowly we can down titrate the dose of insulin based on the level of sugar. And at one point of time, probably after 3 weeks to 1 month, we can come back to the normal dose of gliptin, whatever was given, provided the sugars are very well within the normal limits. Our target HbA1c for any age group, particularly elderly, less than 7.5, still a relatively younger patient, less than 60 or so, our target is around 7%, and around 45 to 50 target is around 6.5%. So definitely gliptin plays a huge role, sir, particularly in this post-patent era as well as in this pandemic era.
Yeah, you're quite interesting that the COVID itself is going to be causing beta cell apoptosis and beta cell, because the ACE2 receptors are present in the islet cells. And also they have found out that there is upregulation of DPP4 during the infection period. And vildagliptin, to a very great extent, is able to bring down this upregulation. And this will be one of the additive effect when you combine with, and especially when they are more immunocompromised and when they are more into methylprednisolone, other steroids, they have a greater risk of glycemic variability and causing more of inflammation and release of the inflammatory cytokines. Vijayalakshmi, can you just offer some comments on this?
So as far as COVID is concerned, I think not only during the COVID, I think all of us have started seeing post-COVID also the sugars being extremely high. Even after the steroids are being stopped, we've seen patients with very high sugars, very young patients coming back with very high blood sugars. So at that phase of glucotoxicity, especially when the patient is sick, as the previous doctor correctly pointed out, that SGLT2 inhibitors absolutely have no role because they can induce a euglycemic ketoacidosis. So that is something that we should always stop for any patient who's hospitalized. So insulin is kind of the mainstay for treatment in a COVID patient who's admitted. But even after discharge, I think to help the patient overcome the phase of glucotoxicity, the burden on the beta cells caused by both the infection per se, the COVID infection per se, and also the steroids that is given to them. Even after discharge, they should be followed up with insulin therapy for at least a few weeks until they completely recover from it. And gliptins and metformin also should be used in caution again in a patient who is in a hypoxic state. Metformin cannot be used. So therefore, DPP4 inhibitors definitely play a role, maybe after discharge when the patient is fit to go home. But in hospital treatment is completely with insulin, because even with insulin, we are struggling to maintain the blood sugars.
Yeah, I've seen a lot of patients, the blood sugars levels are skyrocketing to 600 and 700. But there's no need to stop the gliptin as such. Yeah, you're very correct that metformin and SGLT2 inhibitors are definitely, and sulfonylureas you can continue along with insulin, provided you have a tighter glycemic control. The problem with the post-COVID, they have a loss of taste and they have a loss of appetite. In those situations, you must be careful in titrating the dose of the oral anti-diabetic medicines. Now, Dr. Vijay Mohan, Shivamohan, can you just highlight they have an increased incidence of new onset diabetes in COVID? What is your message?
Yes, I have seen 3 cases in my center, sir. So actually, I went through the previous reports of one of the person. So that person was actually pre-diabetic before COVID. So she had a HbA1c of around 5.9%. And after COVID infection, her HbA1c was 8.6%. So it might be probably because of COVID infection itself, or it might be apart from COVID infection, it might also be because of the steroid therapy. So I think before, I know it's a very it's a very urgent situation to treat COVID, but you can't make a person a diabetic for a lifetime also. So when you're checking the regular parameters, it will be better that we also go for the HbA1c and the random blood sugar when you start checking for D-dimer or ferritin or whatever other tests. So it's very important we check the HbA1c or a random blood glucose before you start the treatment, before you start steroidal therapy. So like I told you, this patient had checked his HbA1c a year back and it was 5.8. So after COVID, it is 8.6. That almost leaves us with 1.6% short of glycemic control. So in such patients, they would actually post-COVID, they would have already lost some weight, after COVID infection. So we need to start them on a drug which will be weight neutral and which will not cause even more further weight, like metformin. And for this patient, actually, we can start them on vildagliptin with a small dose of metformin, and I think that will be enough to have good efficacy and will be weight neutral also. And there are studies that which shows that on combining vildagliptin and metformin will not have a huge effect on the gastrointestinal symptoms also. So I think it will be a safer choice, a better option, combination of vildagliptin and metformin in new onset diabetes people after COVID. So
I still feel that it is one form of secondary diabetes that you're dealing with. It's not new onset diabetes, a secondary diabetes.
Secondary diabetes.
And many times.
But there are a few case reports of COVID causing type 1 diabetes as well. So there have been a few case reports of COVID causing type 1 as well.
Yes, I've seen one.
I've seen that cases. But once again, if you go, I think we must do some genetic study, whether they are, in these patients, what happens is, I've seen 2 patients who had gestational diabetes mellitus earlier. We must go into the other markers for whether there is going to be a late onset diabetes, or as you correctly told, many times they don't monitor their sugar for a very long time following a pregnancy also. So we must do a genetic analysis, we must do further probing into these matters, unless until we definitely say it's going to be a new onset type of diabetes. I think we are overstretching the time. Can I ask any question answer from the audience so that we can interact in a better way? I think so.
Yeah, sir, there were a couple of queries, but it has been addressed. One query is on dosage of vildagliptin in CKD. I think Shiva sir has already addressed that 50 mg dosage. And the other one is once daily formulation of vildagliptin. Again, we had talked to that parameters. Those are the only two queries, sir.
So can I ask the last comments from Dr. Vijayalakshmi, please?
Sir, DPP-4 inhibitors are definitely a big bone in our anti-diabetic armamentarium. It is a molecule that is shown to have good glycemic control without compromising the safety of the patient in terms of incidence of hypoglycemia, doesn't cause weight gain, it is weight neutral, and it can be used across the spectrum of the disease, right from new onset diabetic, even before metformin if the patient cannot tolerate metformin, to patients right across the spectrum, right to patients who are on insulin, elderly patients, and all that. So it is a wonderful drug, and if used appropriately for the right patient, we'll be able to, it helps us achieve the good glycemic control and prevent the long-term complications, therefore improve the quality of life of our diabetic patients. Thank you.
Dr. Vijayalakappan, please, your comments, please.
DPP-4 inhibitor and metformin definitely plays a huge role in treating diabetic patients. So definitely it can't be wiped out of the treatment protocol. And particularly in this pandemic era, since we don't have other molecules to use widely, we can use a DPP-4 inhibitor and metformin, probably if tolerated well, even for post-COVID patients. And particularly a molecule like vildagliptin in the post-patent era, when there are other molecules like sitagliptin, Saxa, and linagliptin, which the patent is not being released, and cost plays a huge role as far as patients are concerned, since they are not only in this diabetic treatment, they may be on some other molecules like antihypertensive treatment, aspirin, statins, all these things. So the cost plays a huge role. So in that particular context, immediately this post-patency has made us base to prescribe a number of patients, particularly this molecule of vildagliptin. So considering the patient's pocket, vildagliptin also plays a huge role, sir. So I do agree with the other things. And this thing, particularly this economic offering, is also has to be considered.
Dr. Shivamohan, please.
So actually, like, we know that we have to treat the patient and not the disease in common. So we have to treat the patient. So it's treating diabetes or treatment is just like a car. We expect a car with a lot of safety standards like airbags, ABS, traction control system. We are expecting so much for the safety of the patient. So drug, car, apart from the power of the car, the engine, the speed it can reach, it also has to be safe. So in that case, DPP-4 fills in all the blanks. It's very good in terms of efficacy because it can reduce up to 0.7, 0.8% of HbA1c. And it can be used in all kinds of people. In new onset diabetes, where you want to prevent further beta cell loss, where you want to protect a beta cell. You can also use it in elderly people who are also very frail, who are who don't have that much who are very weak. So you don't want more muscle loss. You don't want more weight loss. So in such patients also you can give a vildagliptin. So one more thing, even in CKD. So even in end-stage renal diseases, vildagliptin is very useful as a 50 mg once a day combination. So there is so many safety factors in terms of hypoglycemia, in terms of using it in elderly people, in terms of using it in CKD, apart from the HbA1c. So it's a wonderful drug. And I just want to say that no drug is superior to another drug. Every drug has its own importance. So vildagliptin is very useful. in such scenarios. So I want to thank Alkem, and I want to thank Vijay Raghavan sir, Vijayalakshmi ma'am, and finally our moderator Sundaraman sir. So for this opportunity. So it was wonderful presenting with you, and thank you, doctors who attended the sessions. Thank you. Good night, all.
Okay, that's a fantastic overview about vildagliptin, and you know very well that diabetes is a disease of ongoing insult to the body, a body as a whole, and it has got its own aftermath of the vascular complications and also the morbidity involved, and each scenario is different, where you depend upon a patient centric, not a number centric. We are not bothered about the number centric, but a patient centric. So it becomes very idealized, where we need a therapy where it can answer to many of the abnormalities in the metabolic disorder. At the same time, it must be a safe drug. Safe in the means that one of the important problems is the hypoglycemia involved, rather the hyperglycemia. In elderly population is the hypoglycemia. So we need a drug which is going to be a designer molecule, which is going to be a patient friendly, and it is going to be a compliance and economically viable molecule. So with all this put in together, vildagliptin to a very great extent is able to answer these things, and so becomes an ideal form of therapy. And once again, especially in India, I don't know, in a long run, for a durability, we require a combination therapy, any form of combination therapy. And we know very well the time-tested combination of vildagliptin or any gliptin along with metformin will prove ideal as a form of treatment, and which is also economically viable. So with this, I thank Alkem for giving this opportunity. I hand over the mic to them, please.
Thank you, sir. Sir, before giving the closing remarks, I'll just like to present a couple of slides on latest development of vildagliptin and Connect2 Clinic. So allow me to share the screen, sir.
Yeah, make it sweet and simple.
Yes, sir. Just a couple of slides, sir. Yes, sir. Sir, whether the screen is visible now, sir?
Yeah, yes.
Sir, we have brought the Gluvilda 100 mg OD technology. As in fact, Vijay sir was highlighting, we had manufactured with matrix technology for good control in diabetes. So, sir, we compared this when patency got over last year. So immediately we started working on OD formulation, and we did a 3 months trial. And DPP4 inhibition, we compared with the parent company 50 mg BD dosage and our Gluvilda OD 100 mg, wherein DPP4 inhibition is similar compared with innovator brand. Also, we had done a bioequivalency study wherein it has shown Gluvilda OD is bioequivalent to innovator brand 50 mg BD dosage. So, which clearly shows glycemic control because of the similar DPP4 inhibition is similar and throughout 24 hours. And this study was conducted for 3 months period, wherein it has shown similar glycemic control just like parent company. So I request all the doctors, panelists, and delegates who are seeing this kindly give a try on Gluvilda OD 100 mg, which is also cost economical because our Gluvilda OD 100 mg is only priced at 10 rupees to the patient, and our plain 50 mg is priced at only 5 rupees to the patient. And we have a metformin combination, which is also in sustained formulation, which is again 6 rupees and 7 rupees. I request all the doctors to kindly endorse this brand Gluvilda and Gluvilda OD. So with this, I'll go to the next slide, which is Connect2 Clinic. This challenging times, doctors connecting to the patient is very tough, and like we have this option of Connect2 Clinic, which is operational for last more than a year now. which is a end-to-end comprehensive teleconsultation platform, which is available for doctors, which is absolutely free. Connect to Clinic, doctors are know about it because last 1 year this Connect to Clinic is available in the platform. So many doctors are using this Connect to Clinic. So these are the latest features which I just want to highlight, the latest features which has been added in last couple of months. It is credential based login now, no OTP based login. Doctors can set their own password, so immediately they can log in. So faster login is possible now, and doctor can upload all his or her patients in C2C platform and in the My Patient tab. So doctor can view the details of the patient at any time now. Prescriptions, both e-prescription as well as manual prescription can be uploaded in Connect to Clinic. Now this prescription can be shared through email as well as through SMS to the patient, which is again more convenient for the patient. And last part is provision of adding the alternative number by the doctor. Clinic doctors, wherein a secretary will be managing all these platforms, and the final consultation will be managed by doctors. So there we have alternative number option is also can be added, so that they can log in and keep the things ready, so that doctor can immediately get into the teleconsultation and give the prescriptions. And there are other features which is like instant consultation. If there is any emergency consultation which is required for the patient, doctor can immediately share the link instead of prior booking like with other telemedicine platform. There is instant consultation option is available, wherein immediately patient can click that link and get into the consultation. And 3-way consultation is also available now. This patients, elderly patients, wherein a caregiver support is also required during telemedicine, their separate link can be shared by the doctor, so that caregiver can also join for Connect to Clinic, so that it will be more helpful for the patient in terms of consultation and giving all the patient history detail. There is a new feature which has been added recently, which is Med Update, which offers specialty-based content on latest developments on drugs which is happening in the industry, and all national international journals are uploaded in the Med Update, where doctor can access this national international journals. Full text articles are available at no extra cost, and if there is any other article which is required by the doctor can send a query which will be addressed within 24 hours by Connect to Clinic. Patient education module is also available, where doctor can share the patient education videos to patients, so that patients' complaints will be more better. And as I mentioned, staff number can be added, so it can be easily done. Physical consultation, doctor can now do in-clinic physical consultation with Connect to Clinic. So to know more about Connect to Clinic, doctors can get in touch with any of the Alkem team member, where Alkem team member can help you in this regard. Yeah, thank you, sir. So with this, I like to give my final closing remarks. So firstly, I like to thank our moderator, Dr. Sundaraman sir, for accepting our invitation and moderating the panel discussion today. It was a good discussion. We covered all the topics, and it was a very quite informative one on even parameters which is not being covered, like it is completely covered on Clifton, so that it will be more helpful for all the delegates who participated today. Sir, I'm sure all the delegates will be appreciating the views which has been presented by all our panelists and moderators. I'd like to thank all the panelists for sharing your clinical views and experience on Vildagliptin, which will be more helpful for all the doctors who had attended today. Sir, at this juncture, we like to salute all the doctors and paramedicals who have been contributing immensely in these challenging times. Sir, we at Alkem will continue to serve doctors and patients by making our products available, especially Gluvilda, Gluvilda M, and Jupiros and Volcom. Thank you, sir. Thanks for the opportunity given. Good night, sir.
Thank you very much. Thank you. Thank you to everybody, Dr. Shomogan, Dr. Vijay Lakshmi, Dr. Vijay Alagappan.
Thank you, sir. Good night.
And Alkem.
Thank you, sir.